It's November, and that means it's Men's Health Awareness Month. And with me today, I have RadNet radiologists, Dr. Robert Princenthal, Dr. Jason Sinner, and Dr. Mark Stein. Welcome, all of you.
Thank you.
Thank you for being here. So, radiology covers an awfully broad spectrum. So, we're going to start with you and have you kind of give us an overview of, well, first of all, why is it so important about men's health?
Lisa, that was a very good question. As you know, the main drivers of healthcare access is dictated by women. They're used to getting screening exams from a young age, from their pap smears and seeing their doctors, and they learn to overcome many of their fears. Unfortunately, men don't have that, and they're wimps when it comes to getting access to their health care. They're afraid, many times they're working, they don't have time to make access. So frequently, the men we do see in our centers are the weekend warriors who hurt themselves and they come in for an MR of the joint or the back, or only if they have a significant problem to have addressed. Mm-hmm. But fortunately for imaging and radiology, we have really nice non-invasive screening studies to help identify some of the most common healthcare problems in a very easy way for early detection and improved outcomes.
Right, and some of those things we're going to talk about a little bit later. Why do you think men just don't want to have anything to do with going to the doctor? I mean, anybody could chime in, but what are your feelings? I mean, so you said they're wimps or they're busy, but what would you say?
I think a lot of it has to do with the fact that they're just not programmed from the very beginning. You know, I think that to Bob's point, I think women tend to have more exposure from a young age, and so they're used to it, and men just aren't.
Okay.
I think men are also inclined to believe that they are above all of that they're not going to get sick, that they're not allowed to get sick, that this sickness is a female disease to some extent, and they don't want to admit that there's a weakness that they have.
Okay.
I also have to think that, not to be chauvinistic, but if men are working, I think it's harder for them to ask for time off to get these exams scheduled. And that's why one of the things we do at RadNet is we have a lot of evening and weekend hours to make it easier for the working men and women to get access for these types of exams.
Oh, well, that's perfect. I mean, I would say that, you know, if you're working 14 hours a day, then trying to go to the doctor would be quite hard, but that's great that you have those hours. That's perfect. What kinds of diseases does radiology provide a positive benefit for?
Well, some of the most frequent cancers that we can screen for or other significant healthcare conditions would be lung cancer, colorectal cancer, heart disease, prostate cancer, and of course RadNet's mainstay is breast cancer awareness with mammography.
Okay.
But we're here to focus on men's health,
right.
So for the most part we'll leave mammography for another time.
Okay, and I find it also interesting you were talking about you can do screening and then other testing for some other things like dementia now.
Yes.
Okay, good. We'll talk about that one just a bit. How about what do you see as radiology providing a positive benefit for what kinds of things?
I think for a lot of the diseases he's talking about, but I think one thing I would like to say, breast cancer does occur in men.
Right.
And we need to be aware of that, and even though we don't do screening for it, men need to be aware if they do develop a mass to go to the physician, because that's a fairly fatal disease, particularly in men.
Right.
About 1% of all breast cancers occur in men.
No kidding.
And so there is an actual screening paradigm for men, men who have had a previous breast cancer, men who have a genetic predisposition, things like that. And then of course, you want to obviously respond to any sort of palpable abnormality or something like that, because the problem, even though the frequency is far less, they tend to be at a more advanced stage because they ignore it. And
well,
so,
look how many times we're all told from a woman's standpoint, oh, you know, don't make sure you do your checking and you go every year. So when do men need to notice any of this? Is there an age time frame or?
No, I think anytime you just need to be aware of your body like most women are, and you know, make sure that you respond to it. That's the most important thing, is actually responding to it.
Okay, and there really is no testing that you do for men prior, right? There's
Correct.
no test. Okay. All right.
The other thing where what Bob mentioned is particularly lung cancer, and particularly in this community where there's a fairly high incidence of smoking, that's the one area where radiology provides a significant benefit.
Tell me how.
We have now brought in a screening test, a low-dose CAT scan, specifically designed to detect lung cancer and lung cancer only, really. And it's a very low dose, and it's been shown that it reduces the mortality by a significant amount.
Okay.
People start to worry about the radiation dose, and that's going to be the first question, but the radiation dose is so low, the estimate is it's at 1/2000th less the risk of radiation to the risk of developing the lung cancer.
Oh, wow.
So this is really why one of the major areas where we can be of benefit, and some of the other areas that Bob's going to talk about and Jason's going to talk about.
Okay. All right. Well, that's very good to know.
Regarding the risk of radiation, a lot of people want to put it into a concept that they understand. I think you get more background radiation flying from New York to LA than you do from a low dose chest CT. So just to put it into perspective, that's a risk everybody assumes and takes without questioning it. They really shouldn't question getting a diagnostic study that may save their life.
Okay.
And I think that goes for all our diagnostic studies. You weigh the risk and the benefit. And the radiation risk is there. Nobody's denying that, but it is very, very small.
Exactly. I mean, it's probably also like when you go through the TSA thing, you know, well, I'm really worried about the radiation, but you really shouldn't be. Okay. Cardiac disease, #1 killer for both men and women.
Yes, everybody thinks that cancer is the #1 killer, but statistically, cardiac events are the #1 killer for both men and women, more than almost all the cancers combined.
Wow.
And with a sedentary lifestyle and with our population having a higher BMI or body mass index, not exercising and putting on a few pounds, those are all the relative risk factors that can lead to cardiac disease.
Right, right.
We have some excellent tools to help us identify those patients.
What kind of tools?
The first step would be a cardiac calcium score.
Okay.
And with that, we can actually measure if a patient's developing atherosclerosis or calcium in the coronary arteries. So even if your cholesterol is upper normal and you're being maintained with statins or Lipitor or Crestor, you want to find out, is it helping and reducing you getting the end-stage disease? So if you have an elevated calcium score, that leads to an increased likelihood of you having a cardiac blockage. But what it does tell your doctor is that you should be managed more aggressively medically with diet, exercise, and a higher dose of statins to try to control that variable of elevated cholesterol leading to atherosclerosis.
Got it. Okay. All right. Good to know. What about, does anyone else have something to say about that?
One other very good use for it is patients who cannot take statins. As to whether you want to put them on one of the newer drugs, because if the score is negative or 0, the risk of coronary artery disease is very low. And it will push the physician to be more aggressive with an elevated cholesterol or lipids.
Okay.
What we do at our center to follow what Dr. Stein said with the benefits of lung cancer screening, when we do a calcium score of the heart, we also include a low dose screening of the chest looking for lung cancer.
Oh, okay.
So it's a 2-for-1 type of exam where we get to screen for the most common causes of harms for both men and women.
Okay. And the type of test that it is it just a scan? Is that all?
It's a CAT scan. It's
Okay.
a CT scan.
Okay.
And it's over in less than 5 minutes.
Right. So it's super easy to do. Okay.
And with similar risk factors come other types of disease processes as well that radiology has the capacity to detect. We use ultrasound usually in symptomatic patients, not really as a screening process, but patients that have those risk factors that are at risk for that kind of stuff. We can use ultrasound to check the vasculature, the arteries in the arms and legs, and the carotid arteries that go to the brain and supply the blood to the brain. We can look for and detect plaques and things that could cause blockages in the future, and that will also kind of help guide treatment for these patients in order to keep them healthy.
How do you make a decision as to what type of radiology you use? I mean, is it based on history or the findings that you do find?
I think it's really important to understand the clinical question.
Okay.
So we rely on maintaining a great relationship with our referring doctors. So if the clinical question is, do I have atherosclerotic vascular disease, then the answer to that study would be a calcium score.
Okay.
The question is, do I have risk for a cardiac blockage? That's a different clinical question. Do I have ischemia? And then we need to do a more functional study, and you would evolve into CTA or a cardiac angiogram study, and we can also do nuclear medicine studies to look at the heart to separate out is there disease versus how significant it may be.
I see.
And we're, I think one of the important components to remember about radiologists is that we're not there to just interpret studies. We're consultants.
Okay.
And we want to continually make ourselves available to our providers and our patients in order to help guide them into the right direction.
Okay. Okay.
To just continue on what Bob said, for the indications are what we really look for. A number of years ago, whole body CT was something that was real common. We had one right here at the Spectrum that we used to read for, and over the years we realized that it probably wasn't achieving what we thought it would achieve. There was some initial work. So we like to depend on our referring clinicians to help us to go one way or the other rather than just shotgun it and just unnecessarily radiate somebody for an unnecessary procedure.
Right. While we're on that subject, colonography. So I'm gonna have you talk about that only because we're talking about the way that we use this. So tell me how we use that.
So CT colonography is a great test. It's a test that has, however, not really become mainstream. And there are a couple of reasons for that. And the one is that the gastroenterologists feel that by doing a regular colonoscopy rather than a virtual colonoscopy, which is what we do, they can actually do some treatment and diagnosis at the same time. And there's something to be said for that, and I actually agree with it in a lot of cases. However, there are patients who are unwilling to undergo a colonoscopy, are scared of a colonoscopy, or are at risk for doing a colonoscopy because they've got cardiac disease or some other disease, or they're on anticoagulants or blood thinners.
Okay.
And that's really where I think CT colonography right now is located, is for those patients rather than for the routine colonography. However, it is a much cheaper procedure. It's probably easier on the patient, and the results in good hands and experienced hands are very similar to a routine colonoscopy, but it's to some extent a turf war, but it also does have the ability when you have a colonoscopy to get an actual diagnosis at the same time rather than have to have two procedures.
Has that been around for a while?
It's been around for a fairly long time. It started about 12 to 15 years ago.
Oh, really? I don't
and then there was a peak, and then it kind of went down again, but it's coming up, I think, as people are looking at costs.
Oh, okay. Well,
And
and then
it-
especially if they're taking those thinners, then that would be something.
Yeah,
to be
and the other
considered.
time apparently that the other time it's being used is in patients who need to have, if they're going to have a heart transplant or some other test, and they just need to do a quick screening. It's an easy way to do it.
Okay. Okay.
We've just received approval for a reimbursement code recently for virtual colonoscopy. So before there were some challenges in having the insurance companies justify it as an accurate screening tool. So that battle's been fought and won.
Good.
And the other area that we get referred for virtual colonoscopy are patients who've had the traditional optical colonoscopy that was incomplete. In other words, there were some technical challenges. The GI doctor couldn't get all the way around the colon, so we frequently get patients who were scoped that day, they've already been prepped, and then they come to us so we can complete the job.
Okay.
And the VC virtual colonoscopy or colonography also gets an entire scan of the abdomen, the internal abdomen, as opposed to just in the lumen of the colon. About 10% of radiology exams have incidental findings. So you may notice some calcium deposits within the aorta, which could clue the referring provider into the fact that the patient has atherosclerosis, and that's an additional diagnosis for something that they want to treat.
Right. Okay.
That's a two-edged sword, though. Sometimes we
Absolutely.
find incidental findings which we
Correct.
can lead to unnecessary tests, and that's actually one of the problems with doing any of the screening tests that we need to be aware of, that there
Right.
are findings that may be incidental and can cause further workup, and we are always aware of that, and patients should be aware of that, particularly in the chest. When you talk about lung cancer screening, we will often find incidental findings that have to be followed, and patients need to be aware of that.
Okay. All right. Let's talk a little bit about cardiac imaging. What are some of the things that we're going to see down the road?
Well, I think we've done a great job establishing a foundation with calcium scoring and cardiac CTA and the nuclear medicine functional exams of the heart. But I think where the rubber's going to meet the road is to figure out how can we help lower overall healthcare costs by tailoring more specific exams that are less invasive to predict who may benefit from a cardiac catheterization and a stenting or not.
Right.
Because right now, the cardiologist, if someone has angina, will frequently take them to the cath lab, which is a big, expensive procedure. And if they perceive a little narrowing, they'll frequently put in a stent, and it's hard to tell whether the patient would benefit from that procedure or not. So there are works in progress where radiology, I think, can take the lead in that, and more importantly, provide an extreme benefit with lowering the cost of healthcare by reducing the number of unnecessary non-diagnostic studies and go right to the heart of the matter.
So are the doctors generally requiring, or not really requiring, but are they coming to you more for consultation, or is it the other way around?
I think it really depends on the radiologist. I think like any physician in any specialty, there are going to be ones that make themselves available, and others that are kind of more off in the background, and which is fine, either way. But I think you need to have some that are out front promoting the fact that we're available, and so I think that's so it really I think for all of us in this room, most of our career has been in a consultative fashion.
Okay.
So.
Okay. All right. Excellent. Let's go over a couple of different cardiac imaging exams. I know you touched on them, but maybe you can give us a comparison between a few of them.
Sure. Nuclear medicine studies are designed to figure out if someone may have an ischemic segment.
Okay.
And we're trying to identify either dead cardiac tissue from a myocardial infarction versus stunned or hibernating tissue that may benefit from being revascularized versus people who have ischemic disease. And then there's a whole host of other cardiac diseases. Valvular disease, do they have an aortic or mitral valve stenosis that's contributing to some functional limitations? Do they have a shunt? In other words, is the blood not going through the proper channels and going from the left heart to the right heart inappropriately? So those are some of the studies that we can offer and help and work hand in hand with the primary care doctors as well as the cardiologists.
Okay, all right. And then for lung cancer, are you noticing anything new on the horizon?
Well, there's a lot new on the horizon. There are a lot of new drugs, which is changing the course of lung cancer significantly. So early diagnosis is still the mainstay.
Right.
And I think that's really what I've been fairly active trying to push this, and the new work that's come out has shown the decrease in death rate in patients who are screened who meet certain criteria, and we have fairly strict criteria, and we've got a code which can be used to do that. And it really applies to patients between 55 and 77 years of age who have been smoking more than one cigarette pack per day for about 30 years. And even if they've quit, it doesn't mean that we don't do it. And in fact, it's been shown that the risk of smoking continues for up to 15 years. Thereafter.
Wow.
So we continue to screen those patients. So we've picked up numerous lung cancers that are very small, and everybody thinks, well, I've had my chest x-ray, that's all I need. But by the time we see a nodule on a chest x-ray, it's usually between 8 millimeters and a centimeter, and often that's too late. So what we're picking up is nodules that are 3, 4, 5 millimeters. And we can follow those, and we know which ones to follow, and we pick it up earlier. Chest x-rays, and I still get it, and it's from a lot of our referring physicians, rule out lung cancer screening, and I try and call them and let them know that this really isn't the way to do it right now.
Okay. All right, so education from your end as
Education
well.
is very, very important on both sides. And a lot of our clinicians are learning what to do. And sometimes there are, even though I've given the strict criteria that the insurance companies require, if the patient is at high risk, we will do it without those criteria. So once again, it's the individual patient. We really encourage and if there's questions, as Jason said, we're all available. We prefer that a doctor call us to get the right procedure than us doing the wrong procedure and having to then do the right procedure.
Exactly.
About
Exactly.
20% of advanced imaging studies ordered are ordered the wrong way. And so as much as we can help kind of bridge that gap, we try to do that.
Okay. And then let's have you address how you're using radiology to assess dementia.
Sure. Unfortunately, with dementia, there aren't a lot of ways to treat dementia at this point. In particular, Alzheimer's, which is the big topic. But there are some techniques that we have that can help diagnose various types of dementia and confirm a diagnosis, if you will, or rule one out. And that's a very important component, because the exams that we use, whether it's just a standard MRI of the brain or a PET CT, or there are some additional pharmaceutical drugs that we can give that will light up certain areas of the brain in a particular pattern that will correspond to a certain type of dementia. If those studies are negative, it's a real, it's got great, what we call negative predictive value, meaning that if the study is negative, then the patient doesn't have dementia.
Okay, that's amazing.
The important thing to amplify on what Jason said is that this is important for the family and the individual, because by the time you have overt clinical signs of Alzheimer's disease, AD, or dementia, and since there's very poor treatment options for them, you want to give the family as much time to get their affairs in order, to figure out, well, am I just a little bit forgetful, or is this really something I need to be worried about? So there's a huge benefit for early diagnosis.
And there are some medications that they're giving now that at least help to slow the process down, or mitigate some of the symptoms, but it's not considered a true treatment or a cure.
Okay.
But there's also an overlap of different diagnoses that can present in a similar way. You can have multiple small strokes from vascular disease that could have a patient present like they're having dementia, and that treatment would be dramatically different. So it's important to make sure that just because you have symptoms, it could be caused by multiple different diagnoses.
All right, great. All right, we're going to move on to prostate cancer in men. And wanted to talk, everybody can chime in however they feel. We'll go ahead and start with you. What are some of the barriers, which I know we talked about, from being screened? So is this the same thing as them actually going to the doctor, or is this even further?
This is further ingrained into men's psyche. We don't talk about our private parts. And I think for men, especially as they get older, the fear of not being potent or virile really comes to the fore. And with Thanksgiving coming up, we've all sat around our family Thanksgiving table, and there's been an Uncle Harry who had his prostate out 20 years ago, and he has the side effects that men really are unhappy about, what we call I squared, impotence and incontinence. And that was a not insignificant side effect of having the prostate removed surgically. So a lot of men were more afraid of the treatment than being told they had the disease. So we've had a lot of years of fear and misinformation that prevented men from getting screened for prostate cancer. And then unfortunately, just the way the government with the US Preventative Task Force came out with controversial mixed messages about the benefits of breast cancer screening, in 2008 and 2012, they did exactly the same thing for men with prostate cancer. So they recommended that PSA screening didn't work. So in 2012, nobody was getting PSA screened, and now as a result, we're seeing a lot of men presenting with advanced late-stage disease simply due to the lack of screening. But to get back to answer your question, we've now have made tremendous progress in being able to detect prostate cancer when it's early, and the urologists have made tremendous advances with the robot so that the process of removing the prostate is much less morbid, and the side effects of I squared are reduced.
Oh, that's great. That's great. Very good. All right. Anybody else care to comment on that?
Do you think MRI should be used as a screening test, or as a, and when should you use it, when as a
Thank you for that great leading question. That's a low-hanging curveball over the plate. Everybody now talks about level 1 data. And level 1 data is randomized clinical control studies with a large group of patients over time to try to prove a hypothesis. Is this working or not? So the problem with prostate cancer is there's a long lag time from diagnosis to recurrence and from recurrence to death. The mean time of death after recurrence is 17 years. So it takes a lot of data to show a statistically significant improvement. But just this year we have level 1 data from the PROMISE trial and the PRECISION trial, and they clearly show not only a benefit with mortality reduction, but cost benefits as well. And the conclusions are that any man, before they consider being poked for a prostate biopsy, get an MR first. Because the negative predictive value of a normal read is extremely high. We can rule out significant disease with greater than a 90% confidence level.
Okay.
And then conversely, if we see a tumor suspicious nodule, we can direct the urologist to stick the needle in the aggressive area, so we can encourage them to have fewer needles and a higher diagnostic yield, which leads to improved outcomes.
And then how is it that the doctors are educated for choosing an MRI versus the other?
A lot of this is now being driven by men.
Okay. That's good.
You know, we've all gone to a lot of the wellness communities, the cancer support communities, and these patients are incredible. They are knowledgeable, they're passionate, they want to get the word out because, again, some primary care physicians may not be aware of the changes in guidelines. PSA screening is now advocated, but a lot of people don't know that MR is cost effective. They think it's expensive.
Okay, good.
And there are a lot of precursor tests you can do, like a 4K blood test, but the 4K blood test costs more than a prostate MR and isn't as specific or sensitive. So we really need to educate both the primary care doctors, the urologists, and the patients and let them know that RadNet provides easy access for getting quality prostate imaging throughout Southern California.
That's great.
The other advantage of the prostate MR is patients who've had biopsies that are negative and the PSA is still high. And these patients get rebiopsied and rebiopsied. The advantage of the MR is that we can find prostate cancer in areas that are not normally biopsied, or that the biopsy has missed. And I think this is also the point that Bob is making, that it's very important to know where to go, rather than going blind and doing multiple or 12 samples in, just randomly. We can actually go directly to where the suspicious area is, which makes it an easier biopsy and a biopsy that will have a result, which is the most important thing.
To amplify on that, I think the reason the government came out against PSA screening prior to the advent of quality prostate imaging with MRI is that the usual workup paradigm was if a patient went to their primary care doctor and had an elevated PSA, they would go to their urologist and get a non-guided prostate biopsy, what we call poke and hope, where they would put 12 needles into the gland and hope to find a cancer by chance. And frequently, prostate cancer is scored or graded on the Gleason score. So if they hit the corner of the cancer, they would get a low-grade result, and they would tell the patient, well, we don't know what you missed. It's going to be safe to remove your gland, and that way we don't have to worry because their biopsies weren't accurate or specific. But now with prostate imaging, we can maintain men on what we call active surveillance or watchful waiting. If they have low volume, low grade disease, these tumors frequently don't progress quickly and they're frequently non-lethal. So instead of just having a diagnosis and surgery, now we can monitor them with PSA and MR and maintain them with their prostate intact for a much longer time and have an improvement of mortality.
Oh, that sounds very encouraging. Very encouraging.
And very true. It's
That's
a very important thing. Active surveillance is now becoming a standard.
Okay.
And then this is a community where we see a lot of patients with prostate cancer. They say that by the time you reach 99, if you reach that, you've got a 100% chance of having prostate cancer, but it's not a prostate cancer that's going to kill you.
Exactly.
And the key is to help us find, and the other advantage of MR is it can help grade or give you an idea of how severe the prostate cancer is by the MRI appearance.
Right, right. And in continuing with that, let's just touch real quick on what's coming down the pike. Are we going to continue with this type of testing, or is there something else?
Well, I think one of the challenges with prostate MR is that there was a barrier of entry to having radiologists be trained and experienced in reading these studies accurately. There's a steep learning curve. And I think fortunately with RadNet, it has a broad footprint and it has many gifted radiologists who've taken the time to master this and can provide extremely accurate outcomes comparable to the best academic centers. So a lot of urologists would lose confidence. They would order an MR and it would be read poorly, which is worse than not having an MR at all.
Right.
So now we've improved and standardized our interpretation. We're tracking and auditing our outcomes. So we have the data to prove to the urologist that we know what we're doing.
That's great.
So now everybody, I think, is caught up and they're recommending prostate MR. But now the question is, prostate cancer and breast cancer are two sides of the same coin. So each year, roughly 200,000 men and women are diagnosed of their respective diseases, and 30,000 men and women each year die of their diseases. So while Dr. Stein says that many times prostate cancer is indolent and may not kill you, if it's caught late and if it's spread out of the capsule, it can be very lethal. It just takes a longer time. So Dr. Sinner is doing a lot of really good work with PET imaging, with PET isotopes, to help detect prostate cancer recurrences.
Okay, well, that's great. That's good. All right, well, before we end, what would you like to say to the men in our audience for Men's Month, Men's Health Month?
I think the first thing is they need to get their physicals done. They need to see their physicians, their primary care physicians. They need to discuss with them their lifestyle and be honest about their lifestyle, because the things people always lie about is smoking. They'll never tell you how much they smoke. And they need to discuss these issues and symptoms with their physicians and not think that because they've got a symptom, it's too late to do anything.
Okay.
I think that's really the key. We have tools to diagnose diseases early that are treatable without major complications.
Okay, excellent. How about you?
Yeah, just similar. Be diligent with your healthcare. Pay attention to it like you would any other facet of your life. It's not going to go away.
Right.
You really have to be on top of it, or else that's when the bad stuff happens.
Right, okay. And lastly?
This is the time of year where everybody signs up for their new health insurance plans.
That's right.
Whether they have private insurance or Kaiser or Medicare, we have till December 1st. Fortunately, there are some very positive things in the new healthcare reform legislation where screening exams are now obligated to be covered free to the patient. Don't let cost be a barrier to getting access to healthcare. It's free, you're paying for your insurance, use it.
Thank you. Well, thank you all for joining us. I really
Thank you.
appreciate it.
Thank you, Lisa.
And if you would like any information regarding the things that we have discussed here today, please go to prostatemri.com or radnet.com. Thank you for joining us.